Week 6 lecture, Chapter 32, Care of the Patients with Non-Infectious Lower Respiratory Problems. The objectives of this lecture is to identify patients at risk for lower respiratory tract disorders and use the nursing process as a framework for care of the patient with asthma, COPD, CF, sarcoidosis, BOOP, and lung cancer. Chronic airflow limitation. Chronic airflow limitation includes the chronic lung diseases COPD, chronic bronchitis, pulmonary emphysema, and asthma. I want you to know that under the diseases for chronic airflow limitation, you should know that these diseases fall up under this category. So, once again, the chronic airflow limitation includes the chronic lung diseases such as COPD, chronic bronchitis, pulmonary emphysema, and asthma. Right here is just a picture of somebody with that type of obstructive disease, as you can see right here where I'm pointing. Chronic obstructive pulmonary disease, which is the first one that falls into that, um, is COPD. That's what we call it. Now, up under COPD, you have two categories, mainly emphysema and chronic bronchitis. Um, these diseases are characterized by bronchospasm and shortness of breath, which is dyspnea. Um, if there's tissue damage, it's not reversible and it increases in severity, and eventually it leads to respiratory failure. So, a lot of times you'll see these COPDers, and that's the reason why when we talk about people, like for instance, then they put them on hospice, because they know that once a person is diagnosed with emphysema or chronic bronchitis, they will not come. It's not reversible. It's usually going to get just more severe with time. So if you remember me telling you in the past about this, that's the reason. Okay, to continue, um, like I was saying before, the COPD, which includes emphysema and chronic bronchitis, is characterized by spasm and shortness of breath. I want you to know that COPD, which stands for chronic obstructive pulmonary disease, is there's like two main disease processes that fall up under COPD. Those two main disease processes are emphysema and chronic bronchitis. And I also want you to know that these are not reversible in nature. So they increase in severity. So when you meet somebody and they have COPD, you generally it increases in severity. They usually get worse as times go on, and it eventually leads to respiratory failure. The next disease process is asthma, and that falls up under um, this category. Asthma is generally an intermittent disease. There's a reversible airflow obstruction and wheezing. Why asthma makes it hard to breathe, air enters into the respiratory system from the nose and mouth and travels through the bronchial tubule. In an asthmatic person, the muscles of the bronchial tubules usually tighten and thicken, and the air passages become inflamed and mucus filled, and it's making it difficult for air to move. But if you have a person that's non asthmatic, the muscles around the bronchial tubules are relaxed and the tissue is thin, and it allows for ease of flow. So, as you can see, like on this diagram here, there's a difference between the way that the bronchial tube looks, where it's open, and you can see there's an easy passage of air that can go through, and then the one that's inflamed from a person that's asthmatic. So that's what is considered. Also, as far as like a person having intermittent disease, I want you to keep that in mind is true. Also, know that the bronchial and asthma, as far as the pathophysiology, bronchial asthma is an intermittent and reversible airflow obstruction and affects only the airways and not the alveoli, only the airways. So if there was a question on the exam and was saying that asthma affects the alveoli, of course you would put no. So it only affects the airways. That's the reason why I showed you the earlier diagram right here, where um, it obstructs, the airway. It obstructs the airway passages. So and then it becomes inflamed. A lot of times that comes through allergies and different things like that. I might be getting ahead of myself, but bronchial asthma is intermittent, like I said. So that means that it'll come and it'll go. It'll come and it'll go, and it affects only the airways and not the alveoli. That is what I want you to know. Airway obstruction occurs by inflammation and then airway hyperresponsiveness. So, the etiology behind that, which as we was taught before, and since you guys been doing care plans, y'all know what the of a particular disease process is. The etiology is classified into different types based on triggering events. Inflammation occurs in response to specific allergens, general irritants, microorganisms, and aspirin. And hyperresponsiveness occurs with exercise, upper respiratory infections, or unknown reasons. So it can you'll have two different types of triggering events. So, like if a person is around a certain allergen or some type of irritant, or even things like aspirin that can make a person have an asthmatic attack. And also, like sometimes hyper responsiveness occurs because of a fact of somebody, maybe exercising, or if they have an upper respiratory infection. There are genetic concerns as far as asthma. Genetic variations in the gene that controls the synthesis and activity of beta adrenergic receptors impact drug therapy. Inflammation caused by allergen binding to um, immunoglobulin, and bronchospasm as a result of airway hyperresponsiveness. Aspirin and other NSAIDs can trigger asthma in some people. As far as older adults, change in sensitivity of beta adrenergic receptors may prompt that, and teach how to prevent asthma attacks. Also, women generally are 35% higher incidence than men, and teach correct use of preventive and rescue drugs. Also know that like sometimes you'll have certain individuals and they'll be taking like inhalers or different things like that. Know that um, once they use them, they can't keep using them, like over and over and over again. Or else they will not be as effective or not be effective at all. Okay. As far as when you are a nurse and you are treating a patient that has a COPD, okay. Um, when you have diseases like that are airway limitations, such as asthma, um, you're gonna go in and you're gonna first and foremost assess the situation with the patient. You're gonna take their history. When you take a person's history, you're going to ask about risk factors such as age and gender and what type of occupation the person may have, and ethnic and cultural background when taking a history from a patient who may have some type of airway limitation disease, particularly when you talk about people with the COPD. The COPD is more often in older men. You're going to ask about smoking history, ask the patient to describe his or her breathing patterns. Um, can the person, when they're talking to you, speak in complete sentences, or is it necessary to take a breath between every one or two words? Ask about the presence, duration, or worsening of wheezing, coughing, and shortness of breath. And then you're going to also ask about what type of activities basically you know, make trigger, these type of problems. You're going to assess the patient's cough pattern. If the cough is productive, ask whether the sputum is clear or colored and how much is produced every day. Ask the patient to recall the time of day when the sputum production is greatest. Smokers often have a productive cough when they get up in the morning. Non-smokers generally do not. Ask whether sputum production has increased or changed during the past year. Ask about any difficulty with eating and sleeping. And ask about usual daily activities and any difficulty with sleeping, bathing, dressing, or sexual activity. Usually, there are several types of physical manifestations. This will be really important for you to make an assessment. I want you guys to take note of this. There will be audible wheezing and increased respiratory rate. You're going to have an increased cough. You're going to see them use their accessory muscles, such as their like diaphragm, when they're breathing in. Also, um, you're going to look at somebody with COPD. They usually have a barrel chest from air trapping. Like I said, they're going to have long breathing cycles. They're going to have cyanosis and hypoxemia. So please know about that. Also, you want to know about like measuring like the width of the chest and that type of thing. And it, like if you see a person and they're sideways, that's indicative of COPD for them to have just as great of a width, as far as like when you see them sideways as when you see them in front. So that's because of the fact that they develop, that barrel chest over time. Okay. Secondly, when you're doing part of your assessment, you're gonna draw labs. So you're gonna perform a laboratory assessment, and mainly you're gonna assess the arterial blood gas levels. Generally, these levels are drawn by respiratory. Arterial oxygen levels may decrease in an acute asthma attack. Arterial carbon dioxide level may decrease early in the attack and increase later, indicating poor gas exchange. So, what I want you to know is when you get into blood gas levels, I want you to know what the normal range is for arterial blood gas levels. Like we're talking about um, mainly like like their CO2 and that type of thing and O2 levels, and we're gonna get more into that when we start talking about fluid and electrolytes. But I want you to know that initially, um, when a person has an attack, you know that their oxygen is gonna decrease. Okay, when they have an acute attack, but then early on their CO2 may also be low, but as time goes on and they're not exchanging oxygen, the carbon dioxide level would increase. And so you probably will look at more of somebody with the COPD or something like that, where um, it's like a more of an ongoing thing than somebody having an acute oxygen or asthmatic attack. Also, when you do a laboratory assessment, um, you're going to do allergic asthma with elevated serum eosinophil count and immunoglobulin E levels, and you're going to do a sputum so that you can see what type of cells or mucus plugs or epithelial cells are within the sputum as well. So these are the type of exams, and these are the type of things that you're gonna look to when you're assessing a person early on. Another type of test that would be done would be a pulmonary function test. The most accurate measure for asthma or pulmonary function test uses a spirometry, including which includes like the forced vital capacity, forced expiratory volume, peak expiratory flow rate, and then of course they always do the chest X-rays to rule out any other types of causes. So basically, what they're doing by performing this type of test, and there's a small picture here of somebody taking that test, is to see just how much exchange that person is having. Okay, um, I think that I may have failed to mention that the most accurate measure for asthma would be the PFT, and what I'm saying is that there are little things that I say like the most accurate measure for asthma is the pulmonary function test, that you would want to remember those type of statements. For interventions, the most important intervention for a person that's asthmatic would be patient education. Asthma is often an intermittent disease with guided self care, which means that the patient is going to be like taking responsibility for a lot of their behaviors and a lot of the things that they do. So, you need to really, truly, when a patient is asthmatic, a lot of times they can often tell you what type of things will set them off into uh, exacerbation of their disease process. Patients can co manage this disease with their physician, so increasing symptom free periods and decreasing the number and severity of attacks. And I don't know how many of you guys really know about asthma, but I can truly tell you that most of the people who are successful as asthmatics are generally people who are able to manage their disease process. And often, a lot of the people, as they grow up, I know that a lot of times you may have even heard people say that they grew out of asthma. Now, that's where I would want you to make like a really distinction between someone with a COPD, uh, which would include like emphysema or chronic bronchitis, where there's a difference between that, because in that case it gets progressively worse. In asthma, it doesn't necessarily get progressively worse. Uh, okay, so for asthma drug therapy, pharmacologic management is based on the step category for severity and treatment. Preventive therapies used to change the airway responsiveness to prevent asthma attacks. A lot of times, they are used, um, they are used daily, regardless of the symptoms. So, this is part of what we were talking about when we were saying that you're gonna do like management. Um, Rescue drugs are usually to actually stop an attack once it has started. So you're not gonna just be using uh, those type of drugs, rescue drugs as you go on a constant basis. This is just to get you over the hump when you're in the process of having an asthmatic attack. So speaking of asthma, drug therapy, you have what they call the bronchodilators. You have short acting beta agonists. Some of the names of those. would include albuterol. So I do expect for you to know just like some common like albuterol. Another name for albuterol is provenal and Ventolin. Um, those are short acting agonists. They usually use them 1 to 2 inhalations every 4 to 6 hours. Okay. Um, so they relax the smooth muscle, and that and the long acting beta agonists do the same thing. They cause bronchodilation by relaxing the smooth muscles. As far as the short acting, think about albuterol up under bronchodilators. Long acting, think about Ceravent. That's a good long acting drug. So if you just got kind of ideal in your head of what type of things and how you use it. And I think one of the most important things when you think about what they call MDIs or multi-dose inhaler, um, when a person uses an MDI or a multi-dose inhaler, which is the example is these right here on the picture. Um, the most important thing that you teach them is probably maybe monitoring the heart rate, making sure that a person carries um, the inhaler on them, and making sure that the person uses correct technique when they are using the inhaler. Also, you have cholinergic antagonists such as Atrovent. So you got the short term bronchodilators, which is albuterol. Ceravent is the long actor beta 2 agonist, which is Ceravent. Then you have the cholinergics, which is Atrovent. Those are the type of medicines that people generally use. And then you got the cholinergic. I already told you about those. And then and the mexil xanthines. I'm trying to think off the top of my head. Um, oh my God, I can't think of a name of them. But like if you look in your um in your book, somewhere around page 606 or so, you'll be able to find the chart and find some examples. They have what they call corticosteroids, which would be Flovent. They have prednisone. They have those type of things. Um, and then what they call a leukotriene receptor, which would be like Singulair, and they'll take that. That would be just like a tablet once a day. So, most important thing to know about these drugs is to make sure that you take them appropriately, and also make sure when you're taking them that you follow the correct instructions. When you use a multi-dose inhaler, to always make sure you teach the patient with asthma to always carry the relief drug inhaler with him or her, and to ensure that enough drug remains in the inhaler to provide a quick dose whenever they need. So just make sure how there's a chart on page 609 of your book, and it talks about how to use a spacer, what is the preferred or inhaler, correctly, and make sure that you read over that as well. Um, I already talked about these drugs I mentioned with the corticosteroids and all of them were. If you want me to, I can very well mention again the examples of some of the Flovent, and then of course you know about what the NSAIDs are, and leukotriene antagonists, um, which would basically be like a singular, and immunodilators. So basically, what you do is you just know these medicines. Um, Other treatments for asthma would include exercise and activity is recommended to promote ventilation and perfusion. Oxygen therapy is delivered via mask and nasal cannula or endotracheal tube in acute asthma attack. Um, so basically, this is the treatment. um, Status asthmaticus is a severe life-threatening acute episode of airway obstruction that intensifies only if it begins, and often it does not respond to common therapy. If the condition is not reversed, the patient may develop a pneumothorax and cardiac or respiratory arrest. Treatment includes IV fluids, potent systemic bronchodilators, steroids, epinephrine, and oxygen. So basically, this is when a person has a full blown asthmatic attack. I think I mentioned earlier where I had worked with someone once that went into asthmaticus, and she was a young girl, and they couldn't bring her out of it, and she basically she passed. So I mean, it's really nothing to take like it's like serious. It's a serious thing. Okay. I think we're gonna stop on the. We're not gonna do a PSA. Okay. The next one, because we want to keep the thought process going, would be emphysema. Emphysema, two major changes, loss of that happens when you have emphysema. If anybody remembers what does emphysema fall up under, remember I said COPD. Emphysema was one of the things that fell up under that COPD. Two major changes is loss of lung elasticity and hyperinflation of the lung. So you have dyspnea and the need for an increased respiratory rate. So they're trying to take little short, quick respirations. Air trapping is caused by loss of elastic recoil in the alveolar walls, overstretching and enlargement of the alveoli into the bullae, and collapse of small airway bronchioles. Now, emphysemas do affect the bronchioles and the alveoli, where we was talking about the asthma does not. So we want to keep a note of that. And then emphysema falls up under COPD. With like when I was talking earlier about, like for instance, um, um, chronic bronchitis as well. Okay, so the interaction of chronic bronchitis and emphysema and COPD. Okay. You got chronic bronchitis, you have more of an airway problem, but pulmonary emphysema, you have more of a velar problem. But both of them are what they consider an airway problem. Chronic bronchitis. Inflammation of the bronchi and bronchioles caused by chronic exposure to irritants, especially tobacco smoke. Chronic bronchitis, inflammation of the bronchi and bronchioles caused by chronic exposure to irritants, especially tobacco smoke. It results in people having inflammation, vasodilation, congestion, mucosal edema, and bronchospasm. Affects only the airways, not the alveoli. Production of large amounts of thick mucus. Okay, so the etiology and genetic risk is basically these three things: cigarette smoking, alpha, now that's chronic bronchitis, you guys, which falls up under the category of COPD. Some of you will look in here where y'all see etiology and genetic risk under cigarette smoking, which means that's a causative effect factor, right? And then there's a somewhat antitrypsin AAT deficiency, which that antitrypsin, um, which basically makes your lungs and everything kind of expand better and stuff like that. Well, there's a deficiency and or air pollution of some sort. It results in hypoxemia, all acidosis, because we're going to talk about a lot of that next week. Because with the acidosis, people are not blowing off as much. Respiratory infections, cardiac failure, especially core pulmonale, and cardiac dysrhythmias. These are some of the complications because when you have COPD, a lot of your electrolytes you're blowing off. And we'll discuss that a little bit more further as we go along. COPD physical assessment and clinical manifestations. History. Okay, when you're talking to somebody as far as COPD, and you're talking about the problems that involve COPD, um, you're going to, of course, get a history, just like we talked about earlier when we discussed about the history and that type of thing. We talked about the same type of problems and things that you would ask somebody when a person has COPD. COPD, unlike what we talked about earlier, as far as asthma being more prevalent among women, COPD is more often in older men. Maybe resulting because of smoking history or so you may want to assess the same type of things about the breathing. How long is it taking them to talk? Between words, are they having any sputum? And we already talked about how a lot of times smokers often have a more productive cough. Okay, ask about usual daily activities, whether or not it's affecting them when they're sleeping, bathing, dressing, or even sexual activity. Remember, the general appearance of somebody with COPD would possibly be observe his or her weight in proportion to her height. And the patient with increasingly severe COPD is thin with loss of muscle mass in the extremities, although the neck muscles may be enlarged. He or she tends to be slow moving and slightly stooped, and usually the person sits with a forward bending posture because what they're trying to do is like expand their chest more, or when um, so usually people have a really poor activity intolerance. Um, uh, Usually they have several types of respiratory changes, which usually they'll tend to have tachypnea or the and tachycardia as well, because it's like everything seems like it's tending to work faster. Okay. Um, I do want to tell you guys, because like the respiratory rates could be anywhere between 40 to 50. Usually they have rapid or shallow respirations. Usually they're very fatigued. Um, we already talked about the patient with emphysema has limited diaphragmatic movement. which is called excursion because the diaphragm is flattened and below its usual resting state. Chest vibration, which is fremitus, is often decreased, and the chest sounds hyperresonant or percussion because of trapped air. So you may want to make a distinction between that. Examine the patient's chest for the presence of the barrel chest, the what I discussed earlier. With the barrel chest, the ratio between the AP diameter of the chest and its lateral diameter is high, 2 to 2 rather than the normal ratio of 1 to 2. This shape change results from lung overinflation and diaphragm flattening. So you want to know about, like, remember what I was telling you earlier about the lateral diameter is 2 to 2 rather than the normal ratio of 1 to 2. So it's like the same width if you're looking at somebody on the side, and that's what I was telling you about. Cardiac changes, a heart rhythm, um, and it may be, just varying depending on the person. Check for swelling of the feet and ankles or other manifestations of right sided heart failure. Examine nail beds and oral mucous membranes. The patient with later stage emphysema may have pallor or frank cyanosis. Okay. We talked about the ABG values for abnormal oxygenation, ventilation, and acid base status. We talked about sputum samples, CBC, uh, hemoglobin, hematocrit, blood tests to show how they're carrying oxygen, AAT levels, chest x ray, pulmonary function tests. So basically, all the exams and stuff that we mentioned earlier as a result. So for somebody who has a COPD, this is how all of this ties in together when we're discussing things in clinical. They would be more of what one might consider impaired gas exchange person. Um, there's basically a non surgical intervention for chronic obstructive pulmonary disease. Um, so basically, what you would do is if they got impaired gas exchange, is manage their airway, monitor patient at least every 2 hours. You want to encourage them to cough in case they're building up mucus or anything. Oxygen therapy, the drug therapies that we talked about earlier when we discussed the names of some of the bronchodilators and pulmonary rehabilitation. So we talked about these drugs earlier. Um, the Okay, as we talked before, as far as the drug therapy would be our beta adrenergic agents, cholinergic antagonists, methylxanthines, corticosteroids, and NSAIDs and mucolytics, and all of those are basically drugs that would decrease the inflammation, make them cough up whatever type of phlegm they may have. The use of NSAIDs as well for um, to kind of like thin the blood and use as a thinner so that their blood could flow better. And also they're anti-inflammatory. So surgical management, lung transplantation, and this is for people for end stage patients. And like I said before, COPD is non reversible. You're going to do your preoperative care and testing to see if they're a match. Like if you have a donor. Um, Usually, when they do that procedure, they do it. It's a large midline incision, or it can be what they call a transverse anterior thoracotomy. And the post-operative care is basically gauge um, for breathing and signs and symptoms of infection. and so you just take it from there. Ineffective breathing pattern would be another care plan that you guys would use for somebody with COPD. You assess the patient for breathing patterns and respiratory infection. Um, so basically, after you get that person and they have a lung transplant, those are the things like I told you you would assess for. Um, um, you would teach them breathing techniques, position to help alleviate shortness of breath, and you also um, instruct them on conserving energy. Um, you assess the breath sounds, interventions for compromised breathing. You would carefully use the drugs that you give them. You would try to control their coughing as to not cause them pain and stuff because of the incision. They do tend to use chest physiotherapy or what they call postural drainage. You know, when you cup your hand and try to knock that mucus out of the airway cavity. Suctioning, positioning. Sometimes they use humidifiers and hydration to break down the mucus and make sure that it's um, thin so they can cough it out. Um, and sometimes some people have had to have like temporary trachs until their breathing is what it should be. Anxiety would be something that a person with COPD would go through because I mean there's no more better anxiety than somebody that feels like they're smothering and can't breathe. So like as far as y'all care plans, once again, people can focus on anxiety interventions for increased anxiety. Important to have patients understand that anxiety will worsen the symptoms and plan ways to deal with the anxiety. So it's okay. Remember, I told you guys on the last test for you to have people know that there are ways that you should deal with anxiety and that it's okay, and that if they don't calm down, it will worsen the symptoms. It's okay to tell the patient that because I remember the last time we had an exam, some of you guys were worried about that. Also, for a person with COPD, you would have like activity intolerance as a care plan. Remember when I started up early? Now we talked about ineffective gas exchange. We talked about these things. So think about a person with COPD, and these are the type of things that you would use that would apply to them. Um, Interventions to increase the activity level, encourage patients to pace activities and promote self-care. Do not rush through morning activities. So they take frequent rest periods. And as time goes on and they build up their strength, they can gradually increase activity. And they use supplemental oxygen as desired or as ordered by the physician. Um, Last week I talked to you about the 88% and for them to receive it through Medicare, and we already discussed that as far as their oxygen levels are concerned or their pulse ox. Okay, of course, with anybody with any type of surgery, because y'all had surgery already, and anybody with that, you would know that a lot of times they have a potential for pneumonia or other respiratory infections. So they would say when they first would get um, even a plant or whatever, but even if a person just has COPD, they say that for older patients, it's a good idea to avoid large crowds and make sure that you get your pneumonia vaccination. I think it's like every 5 years now, and then the yearly influenza vaccine. COPD, community based care, home care management. Most of these people are on long term use of oxygen and they're on a pulmonary rehabilitation program. It's very important that you teach the people how to use their drugs, especially if they're on MDIs, and to take whatever medications they're prescribed as ordered. Um, Discuss to them about symptoms of possible, infection, various breathing techniques, and relaxation therapy. Another of the many disease processes would be like the cystic fibrosis. It's a genetic disease and it's affecting many organs. Usually, it presents in children through childhood. Usually, you probably see it more in boys than girls. It's present from birth. First seen in early childhood, although almost half of all people with cystic fibrosis at this time are adults when it's managed. It's basically what they consider an era of chloride transport, producing thick mucus with low water content. Mucus plugs up glands, causing atrophy and organ dysfunction. I actually had taken care of a little boy about 2 or 3 weeks ago with cystic fibrosis. The organs affected, usually, this is the way that it affects. They're really prone to sinus infections. In their lungs, they usually have like thick, sticky mucus buildup, which makes them more prone to bacterial infections and widen. They usually have widened airways. Their skin produces like a real salty type sweat, and even in their liver, they tend to have blocked biliary ducts, um, blocked pancreatic ducts, and use their intestines don't fully absorb the nutrition. And as a result, a lot of times you'll see them, they'll have little G tubes or they'll need some extra form of nutrient. And usually, as far as their reproductive organs, male and females, a lot of times they might end up being sterile, or it affects them in some sort of way. Adults usually smaller and thinner, average due to them having malnutrition. Sometimes you'll see them and they'll be real skinny and they'll have a little abdominal distension. They'll usually have GERD or rectal prolapse. Usually they'll have um, foul smelling stools and steatorrhea. They usually have vitamin deficiencies, and they a lot of times end up having diabetes. And this is because of the way that all, like, the mucus plugs and stuff, like, they really affect the organs. So this is the reason why a lot of times you'll see all these type of symptoms. And one of the main things to do when you have somebody with cystic fibrosis is just to manage, each symptom or each complication as it comes. So that, like I said before, I just want you to know about how the profile of this person, how they look. They're really little, and when I think about the little guy that I saw, I went there because he had an infection. He had a respiratory infection, and he had got out the hospital. So that aligns with the things that I'm telling you now. He was on G2 feedings. He was like 15, and he looked like he was about 12 as far as his stature was concerned. So, like, when you think about this, don't think about it in a way like, oh, I'm just trying to memorize all this information. If you could just think about things on how you could relate it to somebody else, sometimes, a lot of times, you can remember that. So they're prone to respiratory infections. A lot of times, they have a lot of congestion in their chest. They have limited exercise tolerance. Um, and then from the mucus, they usually have cough and sputum. They production, use of accessory muscles, decreased respiratory function, increased anterior posterior diameter. And remember, when I talked about the increased anterior posterior diameter, um, I talked to y'all about that as well with people with the COPD. Okay. With cystic fibrosis, the main thing, which is a non surgical intervention, I told you about this earlier. Nutritional management would include to keep their weight up as much as possible, vitamin supplements. If they're diabetes, you're going to manage the diabetes depending on how severe, and pancreatic enzyme replacement because usually those fatty tubes that get lodged up in the pancreatic ducts and everything knocks their pancreas out. Sometimes they have liver problems and they have problems detoxifying like they should. Prevention, they do a lot of chest physiotherapy, um, and active cycle breathing techniques, and as much exercise as what they can tolerate. Um, they want to avoid mechanical ventilation, give a little bit of supplemented oxygen, airway clearance techniques, and like I said, whatever drug therapies that they think is beneficial for that patient, and any education or prevention to prevent any exacerbation of the symptoms, and it's based on whatever they're doing as far as them getting infections or them being a diabetic as a result, or low nutritional maintenance. But in cystic fibrosis surgical management, the only management other than the things that I told you earlier would be a lung and or pancreatic transplantation. It basically does not cure the disease because the genetic defect as far as in the chloride transport in other tissues and the upper airways remains. But if it's done, it extends their life by 10 to 20 years. And a lot of times, patient continues to be at risk for for pulmonary infections, and until one is potentially lethal. Primary pulmonary hypertension occurs in the absence of other lung disorders, and its cause is unknown. So, just know primary pulmonary hypertension or PPH cause is unknown. Pathologic problem is blood vessel constriction with increased vascular resistance in the lung. So, basically, the heart fails, and without any type of treatment, death occurs within 2 years. So basically, you have narrowing of the pulmonary artery, and you have an enlarged right ventricle, which that's basically because of the fact that you have the pulmonary artery and everything is taking more. The large right ventricle gets really big because it's taking more to try to pump, through the vessels. Basically, what they do as far as therapy is okay. I'm sorry. Pharmacologic interventions. They usually will have warfarin therapy, calcium channel blockers, and endothelin receptor antagonists, natural and synthetic prostacyclin agents, digoxin and diuretics, and oxygen therapy. So basically, the whole management is to thin out the blood and to get the heart rate regular, and to relieve them of the fluid, and to provide them the oxygen, and all these type of drugs, or to do that type of thing. Interstitial pulmonary disease affects the alveoli, blood vessels, and surrounding support tissue of the lungs rather than the airways. It's a restrictive disease. It has thickened lung tissue, reduced gas exchange, stiff lungs that do not expand well, and it's a slow onset of a disease. And the most common manifestation is usually them have being just short of breath. The next disease process, and I just want y'all to just have an idea of what they are. Um, is sarcoidosis, which is a granulomatous disorder of unknown cause that affects the lungs most often. It's an autoimmune response in which the normally protective T lymphocytes increase and damage the lung tissue. Um, the most common form of, if you talk about in terms of um, like inflammation and damage, the most common thing that they use to treat it with is corticosteroids. Another type of the disease is idiopathic pulmonary fibrosis. It's a common restrictive lung disease. Example of excessive wound healing. And if you think about the way that this sounds, it's like that. Inflammation that it continues beyond normal healing time, causing extensive fibrosis and scarring. Mainstays of therapy, corticosteroids, and other immunosuppressants. So that's basically all they're doing is corticosteroids and immunosuppressants. Occupational pulmonary disease is just like it sounds, can be caused by exposure to occupational or environmental fumes, dust, vapors, gases, bacterial or fungal antigens or allergens worsened by cigarette smoke, prevention through special respiratory and adequate ventilation. And then um, last is lung cancer. Oh, and it's the leading cause of cancer deaths worldwide. It's poor long-term survival because of late-stage diagnosis. Um, they have bronchogenic carcinomas, paraneoplastic syndromes, and they're staged to assess size and extent of disease, etiology, and genetic risk. Um, so basically, when a person is diagnosed, you're going to do your regular health promotion and you're going to do your assessment. You're going to do the history. You're going to ask them about any type of okay, so you're going to talk about the pulmonary manifestations, which basically mean are they coughing a lot, or are they hurting somewhere in their scapula, what type of non-pulmonary manifestations a person would possibly have. Um, you're gonna see how it's affecting them, like psychosocially, and you're gonna do different types of diagnostic assessments. And usually, you can't just like pinpoint, um, you know, um, you can't. You just have to basically just let them diagnose depending on like what stage and how far along a person is in that disease process. Okay, so you got to know that when you're telling them about this, that the main primary prevention for lung cancer would be directed at reducing tobacco smoking. So you're supposed to encourage non-smokers to avoid passive or secondhand smoke by avoiding environmental exposures. You're supposed to teach the workers in industrial settings about safety precautions such as wearing specialized masks and protective clothing to reduce occupational hazards. As for the surgical management, of course, you have a lot, and it depends mainly, you guys, like where it's located. So here's just like for instance where you'll look on the screen, and it has like a wedge resection here, lobectomy, pneumonectomy. I mean that's like when you remove one whole side of the lung. So That's basically what it is. Also, you probably want to take note, you guys, of what the difference is between as far as left side and right side of the lungs. And remember when we was talking about the anatomy last week, if you go back and you look up those slides, it'll tell you basically what the distinct difference is. One is thinner and longer, and one is shorter and stumpier, and so it'll be important for you to know the difference. Common incision locations, we already talked about that. Right here, medial sternotomy, posterior lateral incision, anterior lateral incision. I've seen the anterior lateral a lot. I've had rarely for problems with lungs. Have I seen this right here, the median? Um, as far as the chest tube placement, we're not going into a whole lot of um, uh, but basically it's showing as far as the chest tube where it's placed within the cavities, the air drainage tube here, and the blood drainage tube, were within the visceral, were within the I'm sorry, within the pleural of the lungs is placed. So that's basically it, and that's just because of post-op. You know, like right after post-op, people have to breathe and they'll be draining blood, and then also you have to keep it like this so that their lungs they won't go into atelectasis and their lungs won't collapse. So you need the chest tube for that reason. So it right here is explaining the chest tube chambers. Chamber 1, which collects the fluid draining from the patient. Chamber 2, which is the water seal that prevents air from entering the patient's pleural space. And then chamber 3 is suction control of the system. So, depending on how much pressure or whatever, it's how much the lungs and stuff, would expand. And this is how they look now. This will be from the patient. This is the air vent. Okay. Um, and water seal. Back in the day when I was there, it was just like really, really prehistoric looking. Um, Nursing care at thoracotomy. Basically, what y'all gonna know? Respiratory management, pneumonectomy care, which means incision, pain management. You know, so you're gonna look at respiratory, incision, pain. You're gonna look at all those type of things. Oxygen therapy, drug therapy, radiation therapy if it's warranted, thoracentesis and pleurodesis, dyspnea. They might have to pull some fluid off, uh, shortness of breath, pain management, and possibly hospice care if needed, you know. Um, okay. Next, we're going to start talking about chapter 33, which is care of patients with infectious respiratory problems. Now, initially, what we was talking about was patients with non-infectious respiratory asthma, all the little disease processes that I described, those were non-infectious respiratory problems. Objective: use the nursing process as a framework for care of patients with infectious respiratory problems, review of infectious disorders of the nose, sinuses, oral pharynx, tonsil, larynx, and lungs. Okay. The first infectious, and I want you guys to be able to, distinguish, because you'd be surprised, would be for you like hay fever or allergies. Believe it or not, those are considered infectious um, as a result of infectious. Okay. Often, rhinitis is called hay fever or allergies. The interventions include drug therapy. which is antihistamines and decongestants, antipyretics, and antibiotics. So you want to make sure that they're not running. You want to make sure that there's no infection there. You want to make sure there's no inflammation there, or swelling, or fever. The complementary and alternative therapy, anything that people, you know how some people sniff all types of different things, or burn certain herbs, and they think that that'll help them with the inflammation of the nasal mucosa, and that's rhinitis. And then, of course, supportive therapy. The next type of infectious, I'm sorry, the next type of infectious respiratory problem would be a sinusitis. Unlike rhinitis is inflammation of the nasal mucosa, inflammation of the mucous membranes of the sinuses is sinusitis. You do non-surgical management, which means that you just use antibiotics, because most things like that are bacterial, and you use antibiotics. You have analgesics for pain and fever, and then you have decongestants. Steam humidification, hot and wet packs over the sinus area, nasal saline irrigations is what. So you're going to do all of that for steam and the hot packs and whatnot, because you don't want to, you want to minimize like the swelling and that type of thing. And here's a good picture. Antral irrigation, Caldwell Luck procedure, nasal antral window procedure, and endoscopic sinus surgery. Okay. Oh, I forgot to tell you that usually you guys, like on this previous slide, they usually like they have like this little translucent light, and that's how they could tell that a person has like really severe sinusitis. So it shows. Um, so a lot of times they'll use what they call strands illumination, and for some reason or another, they say the affected sinus is decreased by the light. Um, but that's how they show it. They also do sinus X-rays, endoscopic examinations, and they do a lot of like CTs and different things like that. In order, a person usually, as far as like the various types of procedures, that was surgical procedure for sinusitis, is usually they do what they call endoscopic sinus surgery. All these little different names. Also, they do where they do the balloon catheter, where they inflate the balloon to keep from getting like for like to promote like the drainage and the mucosal healing, and that might take 4 to 6 weeks or so for them to do that. So this is basically the different types of surgery, and it's not usually that bad. And then, like with anything else, y'all gotta keep in mind respiratory, maintain that airway. Okay. Okay, pharyngitis is sore throat, is common inflammation of the pharynx. So know that that's what that is. So it's a usually odinophagia, dysphagia, fever, and hyperemia, or various signs and stuff. And oh, just in case you guys don't know what odinophagia is, that just means that a person has difficulty swallowing. And y'all already know about dysphagia, and fever, and hyperemia. Usually they call it strep throat being one of the most common medical combinations. Epiglottitis is a rare complication of pharyngitis. So, basically, pharyngitis is just a sore throat. And like the reason why, even though like pharyngitis might not seem like it's common or whatever, or but these infections are like infections that are spread. They're infectious. So I would like for y'all to know the difference. And then as a result, a person may get acute epiglottitis. You know, so and that's just as a result where you can see the swell and you can see the difference right here where it's more swollen on one side than the other. Okay. And then on tonsillitis, everybody knows about that inflammation and infection of the tonsils, and lymphatic tissues located on each side of the throat. They show the white patches or the nodules right here. Um, Here's the uvula and the tongue. That's that little thing that when you open your throat, right here on each side, where that's contagious airborne infection, usually bacterial, and they usually do antibiotics or they usually have to do surgical. If they have to keep giving the person antibiotics over and over again, they'll go to surgical. Now, when you go to surgical and after you finish surgical intervention for a person and they have um, tonsillitis and stuff, then you just have to think of what type of things would a person be looking for as far as that. And when a lot of times when a person has tonsillitis, they always got a mid or severe sore throat, fever, muscle aches, chills, difficulty swallowing. They'll sometimes say they'll have pain in their ears, headache, anorexia, and they have what they call a hot potato voice, which means that their voice it sounds like thick and more like hoarse. Like I can explain it like that. And then if you look at the tonsils, you'll see them, and they'll be like red and inflamed with pus. Now they usually give people the antibiotics, and then it goes away, but then they keep coming back, and then the next thing you know, they might have to do a tonsillectomy or adenoidectomy, and they usually call that a TNA, where they do both of them at the same. And then so the main thing that you would look at. As far as this concerned, you would just make sure that you know airway, the swallowing, the bleeding, making sure you keep the airway post-op. That's the most important things. Peritonsillar abscess, and that's the complication of acute tonsillitis. So that means that they just continuously getting tonsillitis, and the pus behind the tonsil causes one-sided swelling with deviation of the uvula, trismus and difficulty breathing, percutaneous needle aspiration of the abscess, completion of antibiotic regimen. That's what you got going here. And I got a picture. Let me show you here of you see that of the abscess there. Ooh, look how nasty that tongue look and everything. Then laryngitis. Laryngitis, the larynx is the voice. So that means people get, hoarse. And it's acute hoarseness, dry cough, difficulty swallowing, temporary voice loss, which is aphonia, a voice rest, steam inhalation, increased fluid intake, throat lozenges, therapy, relief, and prevention. So basically, when a person has laryngitis, it can come from irritants and that type of thing, and it's just loss of the voice, as a result. Sometimes they can get it because they might have a tumor or something. So you just have to find whatever the cause is of it and treat it accordingly. And for as far as a person they don't want them to. They want them to reduce tobacco or alcohol, and like especially like if you got a person that's a singer, you want them to don't place added strain, no excess use of the vocal cords and that type of thing right there. Influenza is the flu, and it is contagious. I know a lot of people probably think that influenza isn't, but it is. Flu is a highly contagious acute viral respiratory infection. So influenza is a virus. It's not a bacteria, but it's very contagious. Manifestations include severe headache, muscle ache, fever, chills, fatigue, weakness, and anorexia. Vaccination, now that we got the flu shot, it's advisable, and antiviral agents may be effective. Also, you manage it. You manage it. Everybody here knows how you manage the flu. Um, and they say that usually it's the first 24 hours or so that it's contagious, up to 5 days after it began. And usually, the person may feel fatigued and stuff for up to 1 to 2 weeks. But nowadays, the way things are, it seems like it's getting worse. Secondly, we got the pneumonia, and pneumonia is highly, highly, highly contagious. It's excess of fluid in the lungs resulting from an inflammatory process, and it can result in their lungs collapsing. Sometimes people, it could be nosocomial or it could be hospital acquired. Um, um, it can be. I mean, who knows where, how, or where it came from. It can come from various things, but the main thing is to take when a person has pneumonia very seriously. So you're gonna take the history, physical, clinical. You're gonna look at the type of things that's going on with them, where how is it manifesting itself. A lot of times people have a elevated white blood cell count. Uh, a lot of times people catch it because of the fact that they are immune system is really low anyway, and so it makes them more prone to whatever type of opportunistic infections they may get. So this is what it is. A lot of times, people who are older, who has some type of lung disease, um, and different things like that, has poor nutrition, um, they make themselves more prone, to uh, catching some type of pneumonia. So they say that it's very important to get the pneumovax at least every 5 years, especially if you have some type of disease process or something going on. Um, so that's basically what they tend to do. Okay, so um, they say for nurses that the most important thing to teach them is, especially like for like a ventilator associated pneumonia, is to make sure that they have good hand hygiene, oral care, and head of the bed elevation. So this is the thing. And if you look on your page 648 of your book, it tells you ways to prevent pneumonia, and it also shows how to prevent VAP as well. And then you get the various labs when you're diagnosing, and these are the labs that will be tested when a person is tested for pneumonia. And then you just manage it. You manage it like when you at home. You manage it. You got home care, health teaching, health care issues. Uh, Things like if you smoke, if you don't smoke. Eat a healthy diet. Get plenty of rest. Take the vaccines if for the flu because and if you over 65, make sure you take it every 5 years, the pneumovax, or if you have pre-existing diseases, make sure that you do the pneumovax. So it's a lot of little different things that people can do, and give them various resources so that they can prevent it. Then, of course, you guys, they got the SARS, and we just gonna mention this. A virus from a family of virus types known as coronaviruses. The virus infection of cells of the respiratory tract triggering inflammation response. No known effective treatment. Prevention of spread of infection. So basically, don't go nowhere where I know they had said at one point that it came from the Asian community. I remember when it was this big, scare about it and everything. Then there's another one. It's called the avian influenza or bird flu. And it's the same thing. It spreads in birds by oral fecal transmission. So the main thing, you guys, is just coming in contact with these different things. It's just proper hygiene, proper hand washing, and trying your best not to come to contact if you know and you're in the hospital environment, wearing your mask and doing all the appropriate things. Okay. Then TB. TB, you guys, is highly communicable disease caused by the Mycobacterium tuberculosis, and it's transmitted via aerosolization. Secondary TB increase related to the onset of HIV. So basically, they are really saying these are some of the symptoms when a person has tuberculosis. They usually feel very tired, very lethargic. They usually have nausea, anorexia, weight loss. If it's a female, irregular menses, low grade fever. That is like a really big thing. The low grade fever and the night sweats, you guys, is for and feeling really tired. Feeling tired, low grade fever, and the night sweats. That is something, and that can be very irritating to a person to have those three symptoms alone. So basically, you gonna take the history from a person, and you gonna find out what type of things that they are whatever, and but you know that they are on that droplet precaution, and this is what is going on. Usually, I'm trying to think. I think it is the cell mediated immunity develops every 2 to 10 weeks after infection, and is manifested by a positive TB test, the same test that we give all y'all. The TB test is a PPD, and y'all remember how that is read. Okay. And we talked about all of that as far as the integration and that type of thing. Um, okay. Um, Diagnostic assessment, positive smear for acid fast bacillus, confirmation of diagnosis by sputum culture of M. tuberculosis. You could do a TB test, which is a Mantoux test that's purified protein derivative, and it's given intradermally in the forearm. Listen to this, you guys. The induration of 10 millimeters of greater diameter indicative of exposure. Positive reaction does not mean that active disease is present, but does indicate exposure to TB or dormant disease. The interventions, combination drug therapy with strict adherence, um, INA, revamping. These are the type of things that they generally teach a person with. Negative sputum culture indicative of patient no longer being infectious. Sometimes a person can have TB and they could get treated, and then later on, when they do their TB test, they'll always come up positive. Also, on page 655, I want you to take a look at the difference with of a positive skin test. You know, and in duration and how that tends to look. Okay, with the 10 millimeters in duration. Okay. Also, last is the lung abscess. Basically, it's just the necrosis related to a bacteria in the lungs. Uh, Usually, a person tends to have chest pain, and the only thing intervention is for a lung abscess, whatever, because you could develop things anywhere, you guys. Is for them to get antibiotics, drainage of the abscess, and make sure that you give a person frequent um, frequent mouth care because um, usually the bacteria and stuff like that and the breathing and stuff, you want to make sure you don't get they don't inhale in or take in no more bacteria. And then we have what they call inhalation anthrax, and I remember, if everybody remember how back in the day it was this big scare about anthrax, and people was afraid to open up their mail. The bacterial infection is caused by the gram-positive rod-shaped organism Bacillus anthracis from contaminated soil. Um, if it's 100% fatal if it's untreated. Two stages are the prodromal stage and the fulminant stage. Um, Basically, what happens is the the organism is usually a spore, and it encapsulates and it's inactive, and then people spread it around, and then um, it becomes active. Um, the prodromal stage is early, and it's difficult to distinguish from, like, if a person, you would think a person probably had pneumonia or flu. So they would usually have like a fever, fatigue, mild chest pain, and a dry, harsh cough. If the fulminant stage begins after the patient feels a little better, and usually there is a sudden onset of breathlessness, and this sensation rapidly progresses to severe respiratory distress. Usually, you don't want nobody to get to that phase. As the disease spreads through the blood, causing septic shock and meningitis, death occurs within 24 to 36 hours, even if antibiotics are started in this stage. So the key is to get yourself checked out, and you want to take care of a person early on. You're gonna use any type of things like a sealant, amoxicillin, uh, and sometimes people use Cipro, and they'll use one of the mycins or something, or the sealants, and they use it. But they usually say if if a person has been, like, for instance, around um, some type of infection like anthrax or something like that, or may have been exposed, they put them on like 60 days of prophylaxis. So even, before technically trying to diagnose them. Okay, last or not least, a collection of pus in the pleural space, which is pulmonary empyema, and I know it looks nasty. Most common cause is a pulmonary infection, lung abscess, and infected pleural effusion. Interventions include emptying the emphysema cavity, re-expanding the lung, and controlling the infection. And basically, that's it. Usually, a person will lose weight, get chest pains, um, really have quite a problem. That is the end. If anybody has any questions, feel free. Thank you.